Thank you very much. Good morning, everyone. Thank you for the scientific committee for giving us this time to present one of the cases. It's a quite honor and pleasure to be here with you all, and congratulations on committing inauguration of the Gulf Society for Cardiac Surgery. I believe it's not easy to follow two of the excellent pioneers for VADs and heart failure surgery. I'll just continue. We see one of the patients in acute situation, what we do for them. My disclosure is I have a significant help from my chief resident in editing the video. So thank you, Abdul Hadi. It is when you see those kind of patients, like a 59 years old male with a medical background of hypertension, dyslipidemia, diabetes, and chronic kidney disease stage 3. Patient was presented with the Vinton outside facility with acute coronary syndrome and have severe multivessel coronary artery disease. Moderate mitral regurg, MRI was reported dilated cardiomyopathy with the EF of 29%, non-viable, with a scar to the LAD. In spite of all of that, he gets stented. Hopefully no cardiologist here anyway. On the follow-up cardiology, despite the maximum medical therapy, his dyspnea and MR was worsened, and he was admitted to just complete the rest with the TR mitral clip. He had the mitral clip done, and following the procedure, echo was excellent. There was no problem. However, after 2 days, became unstable and required some inotropic support, and echo showed a progression of his MR and from moderate to severe with evidence of clip detachment. So the patient had an intra-aortic balloon pump inserted and were referred to our center with the further management. We did for him an RV catheter, RV study, and his RA mean is 24, RV is 87. It's pretty high there. This is a very sick patients that you encounter them, and you will just go through all options for this patient, which is being burned for them. He's not a transplant candidate, and it was a very difficult situation for him. And those patients, there is a risk of stratification. I'm not sure if it was mentioned before, called HELP, a strategy for referral of those kind of patients who is an IV inotropic support, class 3, end organ dysfunction, EF is less than 35. He already had an ICD, CRTD, and he was hospitalized more than 1 month because, hospitalized for 5 days actually. He's kept having a lot of pulmonary edema, sometimes get intubated, extubated, low blood pressure, progressive intolerance to the directed cold therapy. So the patient was discussed in our team, and those patients, they are really, really sick, and they are Intermax 3, and the heart transplant was not an option. So we have 4 pathology here: severe mitral regurg, big ASD, because of mitral clip, and severe LV dysfunction, severe RV dysfunction, and you could tell and name it. This is a brief video of what we suggest to do. This is the pre-op echo. We show severe MR and severe RV, severe LV dysfunction. Hearts barely move. So what we do on these ones is do the temporary RVAD we put for him, PA graft with the 10 millimeters. And we just do it, bring it as a temporary RVAD for the patient to stay in the ICU. We'll show you at the end how we tunnel this one. So we saw the grafts on top of this. We put the patient on bypass. We do it on bypass because it will, sometimes when you do it on off pump, the patient is really sick, and you can do that one quite easy. And at the same time, you want to create some space for you to continue your procedure, and if there is anything wrong, then we could develop that one. The ASD repair, we try to avoid the cross clamp on that one. I know it is a single cannula, and we learned this one from the congenital people. We just do it fibrillatory arrest and with the guidance to the ASD, and we close the ASD without cross clamp and under hypothermic arrest with the head down, and we had a good one. Sorry, I will just forward this one a little bit more. And then after that one, we do the ring for the LVAD. We size the place. We find it with the TE guided regarding the apex, and we core the LV, and then we just go and find the gold, which is the mitral clip in this place through the LV. And I tell you, it was not an easy one. One of them is detached, so it was a bit easy to remove this clip. The other one, actually, it perforated the posterior leaflet, and the severe MR now come into questions. Do you do it or you don't do it before? But I believe most of the people, they will not do it if they do LVAD. But in spite of that one, we just did for repair for his leaflet through the LV. We were quite lucky to find the place of the tear in the posterior leaflet or the perforation, and we applied multiple Gore-Tex stitches on that one. And I'll just, for the sake of time, let's forward this one a little bit more. I'm not sure if it's not. Yeah, this is the perforated leaflet. You could see it down there. And okay, here. And then we just continue doing the sutures for the cuff of the sewing ring suturing. And I find in those ones who is in acute stages, for those patients, you don't have a good space for them when you put the device on. I'll just go here. Yeah, the device, when we do the device, I do it in two layers. So we needed to open the pleura more and just push it inside. We don't have the Gore-Tex one, but that's a good trick that we should use for our next VADs, to apply the Gore-Tex membrane. And then we do on our anastomosis in the ascending aorta. That's why we opening the pericardium for more space, connection the drive line for this one. And we bring the drive line, we connect that one. After we connect, then we'll go for the RVAD configuration. This is still the outflow cannula. De-airing. Yeah, here we do the tunneling for the RV conduit through the same place of the chest tubes, and a way to do the weaning of the RVAD at the ICU in an easy way, with the just only conscious sedation in the ICU, and we do a femoral cannulation for the right groin or the left, whatever is easier. So in the weaning, we close the chest intraoperatively, and we bring the patient to the ICU, and we do the weaning after the patient doesn't need that one. It take him around 17 days on the RVAD, and then after that we went it slowly according to the echo, and the patient went really well and went home after that one. In conclusion, deciding between uni or biventricular support remained complicated, required a holistic approach rather than considering isolated marker. As Matesh mentioned, LVAD, HeartMate 3 temporary RVAD support can be utilized in the acute setting with good results. Early intervention, careful patient and device selection can further improve the patient outcome. Thank you.